My name is Dr. Aippersbach. For those of you that know me, I go by Dr. A for obvious reasons. Aippersbach is a bit of a mouthful. I am a radiation oncologist, and I just really want to do another shout out to our AV crew. I know it's been a real struggle this morning, and we've just seen this time and time again. We think we've got Zoom figured out, and we do our practices, and then when we go to live, it just doesn't work. So I know they did test run it. So I know all of you at home, I'm sure this was super frustrating, and we are sorry. But I think we're up and going. So let's just work with it. I tend to get nervous when I talk. So if I start like motoring on a mile a minute, just be like, Dr. A, slow down. I was keeping this very conversational today. So this is, actually, I was practicing my talk last night. My husband walked in and he's like, who are you talking to? So I hope that works for everybody. And just know that following Shayna Roselle talking is like the worst place to be. I think she's like one of the best speakers ever. So bear with me. I will do my best, but I'm really excited to be here. So thank you everybody for coming today. So let's see.
You get your
Okay. So hang on. And yeah, that's okay. Oh, yeah. Yeah, but I was using this earlier. Yeah. No, this is a PDF.
Oh, okay. Okay. If you want me to go, I'll do the slides for you.
Are you sure? Okay. All right. Thank you so much. Okay. So next slide. All right. So, and is there a pointer on here too? Oh, look at this. This is technology working. Okay. So I need to keep near to this computer. So some of what Dr. Roselle talked about will be in my presentation. I think we really nicely complement each other. But do bear with us that there's a little bit of overlap, but certainly what Dr. Roselle mentioned is, why do we even need radiation? Like what is the role of radiation in breast cancer? And, what she alluded to is that we're really moving away from the mastectomy paradigm, because in most situations, it does not offer any survival advantage or any local control advantage, typically as long as one adds radiation. And so this is I'm not going to have a lot of data in my slides, I promise you, but this is the role of breast conserving surgery with and without radiation. And this is local recurrence rates up here over time. And we can see that there's a much higher rate with breast conserving surgery recurrences. And if we add radiation, it comes right down. And that actually leads to an overall survival advantage. We think if we prevent a local recurrence, some of those women will go on to have metastatic disease. So if we can prevent that, we can prevent that metastatic disease and that death from happening down the road. This is even probably more prevalent in node positive patients that are high risk. So both in node negative and node positive, there's a local advantage control with adding radiation, and there is an overall survival advantage with adding radiation. So that's why we do what I do. But radiation is really a pain in the behind, right? Most of you that have had radiation, remember, it's a lot of treatments. It's just like if you were prescribed a course of antibiotics, and you have to take those antibiotics 3 or 4 times a day for 10 days, you've got 30 or 40 pills. You don't take them all at once. You would get very sick and your pneumonia wouldn't go away. You have to space them out the way the antibiotics were designed to be used. Radiation, unfortunately, is spaced out daily or twice daily, typically. So in the past, when we started doing radiation for breast cancer, we were looking at about 30 visits. We do it Monday to Friday, so my day is 5 weeks. So that was about 6 weeks of radiation. And though the radiation is very quick, it's nothing more than a high energy X-ray, a couple of minutes, just like going to the dentist, right? You get an X-ray at the dentist. It's very fast, the X-ray part, but there's a lot of lining up part, because you really want to aim that beam of radiation, which, while it's not a beam of light, it has a lot of similar properties to a beam of light. So think about, think about my water bottle. If we're aiming this beam of radiation at the water bottle, think of a flashlight being aimed there. We got to make sure that we're in the right place, because otherwise the flashlight isn't hitting the right spot. Same thing with radiation. So that's a lot of setup time every day. And then, of course, just like with going to the dentist, that's not the longest part of things. The longest part of things is checking in. If you're in the COVID world, doing your COVID screening, getting pulled back to the treatment room, getting undressed to get onto the table, waiting for the hospital emergencies that invariably happen. So, for those few minutes of radiation each day, patients are coming in and they're waiting 60, 70 minutes, right? So it's a long time commitment. So that was the conventional world. And that's what Christ and South Sub was doing when I started. I started about 15 years ago. I can always remember because I came very pregnant. I arrived here very pregnant, and my son's now 15 years old. He just had his 15-year-old birthday. And so that's what we were doing, 6 weeks of radiation when we came. And the university settings had moved away from that. So when I came, I said, I don't think we should be doing this anymore. There's a lot of good randomized evidence that a shorter course of radiation is better. And thankfully, I had great colleagues and everybody supported that decision. So both South Suburban and Christ moved to the shorter course, or the hypofractionated radiation that had been proven to be just as effective as the longer courses in a big Canadian trial. And we were actually one of the leaders to do that in the South side. So I was very proud of that. But it was still 3 to 4 weeks of radiation, Monday to Friday, 5 days a week, 16 to 20 treatments. And so that's called hypofractionated radiotherapy. I'm just going to pull this back. Sorry, I'm still trying to figure out. I'm trying to be on both mics so that everyone can hear me. So I might do some adjustment. And so then we started doing with the surgeons here, we started looking at something called accelerated partial breast irradiation. So now this is a course of radiation where even higher doses of radiation are given. And so you can do it to a portion of the breast, still get the same local control rates for early stage breast cancer, but much more convenient. When we started doing this about 15 years ago, though, it was twice a day. So now imagine all of that setup time, checking in, doing your COVID screening twice a day. Most women could not work during that because you'd have to come like from 8 to 10 to the department, go home for a few hours, and then come like from 3 to 5, right? So actually the pickup for this just wasn't as much as we had thought it might be, because ultimately you can kind of schedule in an hour for radiation for most work days. You can't schedule in like 4 hours for most work days. But now we're going to talk about accelerated partial breast irradiation. It's actually just 5 days, once a day. We're now giving even bigger doses of radiation, but we spread it out every other day, which most people can fit into their work schedule. And we're seeing, again, the same really good control rates. And finally, we were really active in intraoperative electron radiotherapy at this institution. And so I put up a few slides about that. Did you do that or did I do that? So you can go sit down. Okay, thank you. All right. Oh, we are getting this AV thing sorted out. Okay, so partial breast irradiation. So why is it that in the past we used to treat the entire breast, and now, especially in these earlier cancers, we're moving away from the entire breast? Well, that's because we know that it's effective. We've done trials, we've looked at women, and we've realized that about 70 to 80% of the recurrences that occur in breast cancer happen right around where the surgeon, Dr. Kruger, did her operation. She takes out everything she can see. The pathologists check and they make sure everything we can see is taken out. But we know that there's a couple of cells left behind by looking at thousands of women over time. There's no test we can do to check for that, but we know the area of risk in most women is right around that lumpectomy cavity. So if we can target that, we're doing the same amount of good and less bad with side effects, which we'll talk about. And it's really powerful. Let's see. And we've shown that in trials because we know that elsewhere failures are equivalent with or without radiation. So what that means is there is a risk of failing outside of the area of the lumpectomy cavity, but that does not seem to be affected by radiation. So we know that this is a really powerful technique in a subset of women, and we're starting to see that that subset of women is becoming larger and larger. So these are the new APVI guidelines. They actually came out endorsing the shorter course of radiation for low-risk women. And I think we're going to see more and more adoption of this. But at any rate, for low-risk women, excuse me. Now, where did I put my water? All right, thank you. Once I start coughing, I tend to not stop. I promise you, I don't have COVID. I test all the time. Okay. We'll see how I do. I might have to grab a candy because I once I start, I tend to just go into anxiety and just cough more. Low risk women are women that are over 50 or postmenopausal typically. And then the tumor has to be a certain size, a certain grade. It can be either invasive or non-invasive and certain margin status. But if women meet these criteria, they are candidates for a very safe and shorter course of radiation. Breast size plays into it a bit too, because we are now doing the lumpectomy cavity. So where the surgeon, Dr. Kruger, J. Paul and Gumberwala, Albright, where they're taking the tumor out, we're doing that margin around and an expansion. So if you have a very generous breast size, then that expansion is still just a small portion of the breast. So we can give that larger dose and spare a lot of tissue to the normal breast. If you've got a smaller breast size, you're going to be getting the entire breast. So you lose that differential advantage of not treating a big portion of the breast. All right, and my God, excuse me. Now what did I do with my clicker? Oh, my goodness. All right, okay. This is just a shout out to the IORT technique. So this was even bigger doses of radiation. This was one large dose of radiation given in the OR. So the surgeon, Dr. Kruger, and I have worked together on many cases, will go in, take the tumor out. So now those cells that we talked about, the ones we can't see, we can't test for, but we know they're right in that little area, right around where the tumor is. We can directly target the radiation right there. It's a very powerful technique because we're right in the operative cavity. We know exactly where we are because we're right there. We see it. We're in the OR. There are some disadvantages. One, and you'll see in the next slide, it's very labor intensive. We don't have that final pathology because if the margins are positive or lymph nodes are involved, then these people are not those low risk women that should be having this technique. And we were seeing more side effects or cosmesis or fat necrosis issues with the larger doses of radiation, but certainly a very promising technique. So this is what it looked like. This is not our institution. This is just a slide from the internet, but the Mobitron is a way of delivering this type of radiation. But again, you can see just how many people are involved in this process and also just how time intensive it was. And remember, the patient is under anesthesia during this procedure. So it's also, that does increase, it was very, very safe, but that does increase, time under anesthesia and factors like that. So previously then, when we didn't have these external beam techniques that we'll talk about in a minute, we were doing things like catheter-based treatment just around that lumpectomy, again, around that high-risk area. So this is an example of one of those catheter techniques. And again, the advantage was this was put in after the surgery. We could wait until we had the pathology. So we truly knew we had the low-risk women that would benefit from this form of radiation and then deliver the radiation. So we started moving to what's something that's called three-dimensional conformal radiotherapy. So again, radiation is not a beam of light, but it has many, many similar properties to a flashlight. And so you can see here, there's this is a cross section of a woman. Now, I'm not expecting most of you to understand the slide. But this is what it looks like when we take an imaginary slice out of a woman and look at it like a piece of toast. So if your body is a loaf of bread and we pull a slice of toast out at the level of the breasts, by convention in medicine, it's like you're looking at the patient. So this is my left arm. So that over there is the left. This is the right breast that we're looking at in this patient. That area that is gray, that's right where Dr. Kruger or the other surgeons have taken the tumor out. She leaves clips for me. You can kind of see one there. We know that the high risk area is that 1 centimeter around the lumpectomy cavity. So this is a 1 centimeter expansion. And then we expand a little bit more for things like movement and breathing. And of course, I talked about why we want the larger breast size, because you got to have enough breast to be spared for this to make sense. Here's another view of that. These slides are fun for me, but feel free to be like, what the heck? But again, Dr. Kruger leaves a clip right there. So I know exactly where she operated, even if we don't see that seroma or postoperative cavity, because she leaves that clip for me. And in this patient, there was actually another clip there. So we contour or we draw the area that is a high risk area. And then we bring in the different radiation beams. You're going to see some different pictures of that. Again, radiation is not a beam of light, but think of it as a beam of light. And here we use different colors of light. So different, that purple green beam coming in, green, red, all of these different beams of light where they converge, like the flashlight that we talked about. Think of my water bottle as being the tumor bed. If we turned off the lights and gave everybody in this room a flashlight and you all shone it at my water bottle, and there was people on the roof and people behind us, And let's just say we had 100 people with flashlights. There's about 100 people here. Each flashlight beam is only 1%, right? Everyone's got one little beam and it's not very bright, but where our power comes is when we come together, right? As people, also as radiation. And so suddenly where those 100 beams converge, that's where we get the power of the radiation doing its effect with very minimal side effect to surrounding tissues. So this is the slide I just showed. And now with this new technique that we're doing the 5 treatments over 2 weeks, every other day. So like Monday, Wednesday, Friday, Monday, Wednesday, for instance, we actually use something that's called intensity modulated radiotherapy. So each beam of light is further adjusted and modulated. So we can be very, very precise in our delivery of radiation. And then we're now able to do a little cone beam CT. So, you know, those CT scans that everybody gets, we're able to do one with the radiation treatment machine just to really make sure we're right in the right spot. And so again, here's that clip that Dr. Kruger left for me. The purple is the scan that I do for planning the radiation. The green is the scan that's done on the day of the treatment. We overlap them. We make sure everything's in the right place. The bones are in the right place. The clip is in the right place. If not, we reposition the patient. We make sure it's right, and then we deliver that radiation. So that's partial breast irradiation, and super excited about it, obviously. But we're also doing things in whole breast radiation. Not everyone's going to qualify for partial breast, either due to their size, right? Again, if the breast size is smaller, there's no advantage to the partial breast. If they're higher risk, if there's, you know, a desire to cover some of the nodal basins, things like that, we are still treating the whole breast. And the breast is the breast is a structure that curves around the chest wall. So the chest wall has a curvature. And so because of that curvature of the chest wall, treating the whole breast does mean we treat some of the underlying structures. You'll see pictures in a minute. And so we've really worked hard in the last 15 years, bringing different techniques that minimize the side effects, right? Because that's what you want to do. You want to get the benefit of the treatment and really minimize the side effects. So this is a technique that we've been doing now for a while. It's called deep inspiration breath hold. It's really simple, okay? In left-sided breast cancer, sometimes the heart rides up right underneath the chest wall. Not always. Sometimes we can treat patients and there's really no heart at all in that beam of light or that flashlight that we're using to imagine the radiation beam. But when the heart is there, it's actually an important part of the heart that sits right underneath the breast. It's the left ventricle, and we really don't want to give much radiation to that because we worry and we know that there's increased cardiac toxicity down the road with large doses of radiation. So if we can lower that dose of radiation to the heart, or if we can minimize it entirely or take it out of the picture, we don't see those side effects. And so when you take a deep inspiration breath hold, all that is a deep breath in. And so I just have my patients practice it with me. We can do it right now. Then I'm going to turn blue because I always forget to start breathing, but take that big breath in and you're filling your chest wall. And what you do is your diaphragm goes down, and your diaphragm is the thing that separates okay, I'm going to breathe now. Yes, I'm going to turn blue. It separates the lungs from the abdominal cavity, but it's attached to the mediastinum, which has the heart. And so when you do that, when you take that deep breath in, I'll do it again, your heart, if it's right underneath the left breast, pulls back and down. Well, now my heart's actually away from that breast. So I can treat the breast in my patients without treating the heart. Super powerful. So this is a picture of that. So if I just come in with my beam of light, again, this is the left breast. These are clips here again. I'm just going to point out, here's a clip, here's a clip. Now this is the same patient, same clip. There they are, those 2 clips, okay? So this is pre-breathing. This is what we see on the CAT scan. Where's the heart? Yikes, the heart is right under what I need to treat because I need to treat this entire breast and it's curving around the chest wall. Oh, I'm getting a lot of the heart there. I'm getting a lot of the left ventricle. I don't want to do that. Get the patient to take a deep breath in. Heart moves down towards the feet and back. Suddenly, look at that. In this beam of light, there's no heart. There's no side effects. There's no toxicity. Another technique we can use is gravity. Oh, so easy, right? Let's just use gravity, right? We know that as women age, our breasts get less perky. They get a little more pendulous, right? That's just the way it is. The bigger breasts particularly are more pendulous, right? Well, why not use that? Gravity's everywhere. So this is a picture of a model. She's wearing a bra, but you can see that already with the bra on, that breast is pulling away from the critical structures. It's pulling away from the heart. It's pulling away from the lung. And now we will undress the model, but we'll do it into the x-ray. So this is still G. So now we have the x-ray pictures. So now this is a left-sided tumor. When we do prone, this is the left. At any rate, doesn't matter. There's a heart. And here we have that beam of radiation. Again, think of it as color lights. It's not, but you can see I'm getting that radiation beam. It is not even touching the ribs. It is not even touching the heart. Look at this. I'm getting the entire breast. And now, in fact, this is where Dr. Kruger and the other surgeons have left. There's a little clip. This is what I'm worried about. I can boost this entire lower portion of the breast. I don't know if you can appreciate, but it's a darker red. That's, again, that is getting the dose that it needs. The rest of the breast, because this is a higher risk situation, does need some dose. No dose to the lung, no dose to the heart, the ribs, no dose to the heart. Like, this is amazing. All we're doing is using gravity. Why not? So here's just another pictorial of it. I mean, I love looking at these things, but bear with me. We're almost done. So here, prone breast, away from the heart. And now if we flip that woman around, right? Sometimes we do need to do that, but that's where we can use the deep inspiration, pull it out of the way. But just see how that breast sags down here, right? The less perky. Here it smooshes, right? So it's going to be closer to the heart. It just is. Again, if we can pull that heart out of the way with a deep breath, that's great. But if we can use prone, even better. All right. And so as Dr. Roselle talked about, and I'm so glad we have so much, I think, complementary stuff in our slides. I was worried when her slides started coming up because there's not too much overlap, but there is some, and I think it reinforces these great ideas. I, like Dr. Roselle, hang on to my patients. I know Dr. Kruger does too. Dr. Kruger is in the audience. I don't know if the other breast surgeons are here. Sorry, I'm just referring to Dr. Kruger because I see her, but we work with all of the surgeons. We hang on to our patients. We, I think somebody asked a great question. It's like, why are we left in the wilderness to figure this out? And I think our team at Advocate at both South Suburban and Christ, we don't leave you out in the wilderness. We are here. And I always, end every visit, even if, if it's just a yearly visit, like, I'll see you in a year, unless there's a problem. Then you call and you come in sooner. And so we are here to talk about these things. And I really do feel very blessed in oncology that we have way more time. I still think we have more time than a lot of medical primary care doctors do. We can take that time. We can sit and, for the person who asked about acupuncture, I talk about acupuncture. I talk about diet. I talk about exercise. I talk about Fitbits. We'll talk about that. I talk about keeping track of your steps. I'm passionate about it. And we'll talk about some of those slides because we're curing a lot of women. And that means we got to make you look good at 80 and 90. And we got to start planning for that at 50 because we start losing muscle mass. So there are some studies that suggest that women after menopause lose 1 to 3% of their muscle mass a year. So let's just call that 2. In a decade, that's 20%. Well, if you lose 20% of your muscle mass from 50 to 60, and then another from 60 to 70, and another from 70 to 80, you've lost a lot of muscle mass when you're getting into your 70s and 80s and want to be enjoying your grandkids. So we got to start thinking about that. We got to start thinking about that at 50. So plan for the body you want at 80. You got to start doing the work at sooner, as soon as you can. If you haven't started, that's okay. I'm not here to shame you, but I just think it's an area that we should always be working on. So first of all, as mentioned, survivors, you are not alone. Breast cancer, we'll talk about it. The cure rates are going up. We're detecting many cancers earlier. People are living longer. So our survivors are increasing. The risk of getting any cancer, unfortunately, is high. 1 in 3 people will, this is a slide about women, but 1 in 3 women will develop a cancer during their lifetime. So never feel that you are alone. And I heard, the talking about Gilda's Club, and I just want to say there's so many organizations. There's Gilda's Club, there's a Cancer Support Center in South Sub and Makina. There's Christmas Without Cancer. That's a charity that was started by one of our radiation oncology nurses. There's so many people doing good work, and there is good stuff online. There's a lot of bad stuff online, but do know that there's no need to be doing this alone. And Dr. Roselle had this slide, but you can see that in 2006, there were about 11 million cancer survivors in the United States. We're up to 18 million. That's 1 in 20 or 5%. So a lot of people have dealt with a diagnosis of cancer. It is very common and people are living longer. So we got to plan for those bodies 5, 10, 20 years down the road, okay? So being the best version of yourself is something I'm very passionate about, because that is absolutely part of what we're doing in breast cancer. We're curing people. So we got to plan for them living for 5, 10, 20 years after they are cured. As Dr. Roselle showed, breast cancer is still the most common diagnosed cancer in women. These are the 2022 stats. And thankfully, it's not the highest killer. That's still lung cancer. And I will kind of talk about this a little bit. And I think the next slide, well, it's not the next slide, but okay. The mortality trends, and Dr. Roselle brought this up, really have been decreasing. And so it peaked in about 1990. And over that time to, I think, from 1990 to 2020, let's call it, we've seen an over 40% decline in breast cancer deaths. This is huge. This is really significant. We think that's for a lot of the things that Dr. Roselle talked about, the better therapies, but we also think it's the earlier detection and also the increased awareness, right? People are coming in for their mammograms. So they're coming in for their ultrasounds, which, by the way, by Illinois law, the screening ultrasounds is covered. It almost needs to be 100% covered by almost all your insurance carriers. So if it's truly just a screening ultrasound that's done for density, there's an intake, and there should not even be a copay associated with that, because that's actually an Illinois law, which is great. Anyway, so what does that mean? That means we probably saved almost 500,000 lives in that period because we're doing so much better. So again, we're doing better, which is great. Then we need to plan for doing better and make sure we're supporting people 5, 10, 20 years past their diagnosis. Dr. Roselle did this slide as well, but in the 70s, only 75% of people were alive 5 years down the road. Now that's over 90% in all breast cancer comers, and over 99%, as she alluded to, in the early breast cancers. So we don't have the luxury of ignoring the side effects of our treatment options anymore. Because if you're curing 99% of early breast cancers, you better be really prepared to deal with the treatment toxicity that is part of that. And so we're seeing things like de-escalation. And we've seen that actually in pediatric cancers. We've seen that in lymphomas, where as we realize, like, hey, we're actually curing all of these people, but the side effects of treatment are so toxic. Like, somehow the balance has changed. Now we've got to pull back on the aggressiveness of treatment, because it's actually the treatment that may be causing long-term side effects more than the actual cancer. So this is a great point. I think I love the slide. So this is from 2022, and this is actually just the trends in cancer deaths among females, and it goes from the 1930s to 2019. I'm just going to step back. Yeah, no, I'm not. Give me 1 second, guys. Let's try not to wreck everything here. Okay, and so what is really important here, and I'm not going to use my pointer here because I actually need to look at the slide, is that there's certain cancers that have precipitously dropped. So if you look at stomach cancer, that's the blue one. See how high stomach cancer was in the 1930s? So that goes to that question that somebody asked, just an excellent question, like, what's in our food? What's in the pesticides? What are we worried about? Well, it turns out stomach cancer was one of the most common and most lethal forms of cancer in the 1930s. And it went away with a lot of different things. And over time, we've realized it has to do with preservatives, because people didn't have fridges back then. So they used a lot of, I think it's nitrites or nitrates, I always forget, a lot of smoking of the foods. And then there was decreased sanitation. And so we found out that there's a bacteria, it's called H. pylori, that was actually a very common infection, and it gets much less common as people aren't so densely packed, and water and hygiene and stuff are more common. So as people started getting fridges, not being packed in so tight, water sanitation got better, H. pylori infections went down, all of these preserved meats kind of went away. Like, we don't eat as much preserved meats. And look at the rate of stomach cancer. It just like it plummeted, and it's just, it's stayed low. So that's where we see these environmental factors, and we can really say, yeah, that's probably it. And we've addressed that. The other one is the lung cancer. That's the one in red. So you can see that lung cancer was really low. And the reason that we think and pretty much know is that's the case is that women weren't allowed to smoke in the past, right? It wasn't socially acceptable for women to be smoking in the 30s and the 40s and the 50s. It really just started, I think, with movies and things like that. But prior to that, only men could smoke. So actually only men got lung cancer. To develop lung cancer from risk factors such as smoking, it takes probably 10, 20, 30 years. We call it pack years, like how many packs a day have you smoked for how long? And we start to worry after about, like, so if you smoked a pack a day for like 15 years, you're starting to get into that lung cancer risk. 20 years, even longer. 2 packs a day for 10 years. Well, that's 20 pack years. And so as women started to smoke, and it became socially acceptable, look at this, lung cancer rates went way, way up. And then we started to realize that smoking wasn't so cool, and the Surgeon General came out with things, and there was all kinds of smoking cessation programs and such. And like, look at this, right? After people stopped smoking and smoking became less common, look at this. We're just seeing down and down and down. Okay. So with respect to breast cancer is the sort of purpley pink line. So I do think food and things like that are important, but do know that we are seeing this decrease that we talked about. And so that means there are these non-modifiable risk factors, right? We can't help being born female. That really increases our risk of having breast cancer. You can get breast cancer as a male, but it's less common. We can't help, at least I haven't figured out how to stop aging. And if someone can, let me know, because like I said, I showed up pregnant here and suddenly my son's in high school. I don't know what happened, but I mean, you're just born yesterday. How can that be? But so we are working on this, and I'll talk about this because again, I'm passionate about this stuff, but I don't think pesticides, right, is necessarily the answer, because we've seen those increase a lot and the breast cancer rates are coming down. So I'm a survivor. What do I do now? And you're going to be a survivor for decades. So this is where you start to be the 2.0 version of yourself, or the better version of yourself, if you can, right? This is going to be, decades that you're living in a post-cancer diagnosis stage. We talked about learning to trust your body again. I think that anxiety slide that Dr. Roselle put up was great, right? There's different areas of anxiety. And, I finish almost every radiation last treatment with, I'm going to, see you, we'll follow up shortly. You stub your toe, it hurts. It is not cancer, I promise you, right? But I also say, but I promise you, you stub your toe, it hurts. You're going to worry that it's cancer, right? So just come in. I will examine your toe. I will even x-ray your toe if that makes you feel better. That will lead to issues because there might be bunions and there will be things like that. So my first job is going to be to make sure that I'm pretty convinced it's not cancer, which I probably will be if you stub your toe, and to talk you off of that wall. But that is going to be a journey going forward, that you're going to need to learn to trust your body again. It let you down, right? Life was good. Suddenly a mammogram changed your life. Suddenly you felt something in the shower that you shouldn't have. And suddenly your body, which may not have let you down before, in a way has. And you can't really kick your body out to the curb, right? If you have like a cheating spouse or something like that, you can make some decisions. Well, you can't walk away from your body. You're stuck with the body you have. So let's make it the best body that it can be. In that sense, it's never too late to adopt a healthier lifestyle. And everyone can benefit from that. So again, we want to plan for the body that we want at 80, but that's good if you're 75 or 55, right? We still, everyone can look 5 years into the future, 2 years into the future, whatever that is. Let's start doing the work now, because it doesn't get easier if we wait 2 years or 5 years. And I really do think it can be very rewarding, like making healthier choices. And I always joke about things like just keeping track of your steps, right? I sort of like, how many steps a day are you doing? Some people have no idea. I didn't. And so now you guys are going to laugh. My patients know this. I'm wearing 3 fitness counters. I've got an Aura ring. See, this look so unobtrusive, right? Like that thing keeps track of my steps. I've got an Apple Watch and I've got a Fitbit. They all have their advantages and disadvantages, and I love them. And I'm like, here, let me tell you what, this one's expensive, but really unobtrusive. Love it. Apple Watch, short battery life. It's got good, but you know what? It finds my phone. I lose my phone 10 times a day, so I need the Apple Watch, right? And then actually my favorite is the Fitbit, right? The Fitbit actually 7 days of battery life. You can wear it when you're sleeping. It's $109 on sale. It's fabulous, right? But you pick one. And what I find is that I am surprised on days that I'm busy, at days that I'm running over to South Sub, at days that I'm running over to the OR, checking things out, easily get 10,000 steps in the day, like no problem. There are days where, because my office is small and my exam rooms are right there, I might have 3,000 steps at the end of the day. Like 30% of what I do on a busy day. I still feel tired at the end of the day because, you know, I just worked a full day. But I look at that and I'm like, ooh, it's time to go for a walk. I need to take the dog out. You know, hubby's normally in charge of taking the dog out after work. That, yeah, if I've done 3,000 steps, I got to take Lucy out for a walk because I didn't get my steps in. It's just an easy thing to try and aim for those 10,000 steps a day, but you can't do it if you don't know. So track. BMI. This is a surrogate. I'm interested in it. Like, do not, there's so much body shaming in our culture, just so much. And our culture has such unhealthy views around nutrition. So it's always about it being a healthy choice. But a BMI is a good surrogate for, what is a healthy weight. It's not going to be, if you're really tall, if you're really short, if you're really muscular, it's not going to be the same, but it's kind of like, it's a ballpark. Eating a healthy diet, limiting alcohol, sorry guys, and then getting that physical activity. It could be as little as 10,000 steps a day. It could be walking in water. A lot of you have joint pain. I get it, right? Neuropathies, things like that. We put you into postmenopausal state. The joints hurt. Well, a great way, again, gravity, right? Use it. Walking in a pool. Even if you don't know how to swim, most pools, I'm short, they go up to here, right? You go to LA Fitness, the pools are not taller than this. So I promise you, getting into a pool, as long as you can get in safely, grabbing the lane by the side, you can even wear a life jacket if you're really scared of water, walking. Your joints are supported. You actually don't get the joint pain, but you get the cardiovascular resistance of walking against the water. Things like trampolines. Anyways, figuring out what is going to strengthen your cardio, your muscles, helps the mind. Enormously helpful in depression to have 20-30 minutes of exercise a day. Walking is one of the best forms. Doing it in the sunlight. In Chicago, right, we always don't see enough sun during the winter. It's cold out. But if you can get out and walk in the sunlight 20 minutes a day, enormous benefits to your mental health. And of course, not smoking. Hip fractures, right? So if we put you into menopause with our treatments, if we put you onto bone thinners, guess what? We increase your risk of hip fractures. And hip fractures are related usually to serious falls. About 300,000 men and women, elderly, that's over 65, it's actually not that old, is what that statistic is from, are hospitalized every year in the United States for hip fractures. Well, here's the bad news. Women are 3/4 of that number, okay? We just tend to fall more than men. I think that's related to our core strength, which is why I'm pretty passionate about core strength. We have higher osteoporosis rates. Guess what? If we put you on some of the breast cancer treatments, we increase that potentially. And the risk of dying after a hip fracture, it's really high. We're going to talk about that in a second. So this is where we, what can we do to avoid hip fractures? This is one study, I think it was out of Denmark, where they looked at Denmark has a socialized healthcare system, so they have really good data. So like places like Canada and Denmark and those places, they have these registries that are really, really powerful. So they can look at like, okay, these people, had their hip broken, they underwent a surgery, and then they can actually look, are they alive 30 days later, 60 days later, whatever. So the mortality 30 days after hip surgery, 10%, 20% in 6 months, 30% in a year. And now these are happening in older patients. So this is not all related to the hip fracture. In some ways, it's going to be tracking along. Certainly, I think the early, the 1 month, that's probably more related to the hip fracture. But, at 7 years, it's multiple factors. But this is bad news, right? A hip fracture is bad news. If we can avoid it, let's avoid it. let's make sure we're doing core work. Let's make sure, you know what, when I started looking into this data, I hadn't done a sit-up in years. I do sit-ups now, I do squats, I do planks, right? Because guess what? I just hit menopause, right? So I'm thinking, what body do and I've got young kids. My youngest is still 8, right? So how do I want to look when my kid is walking down the aisle at his wedding in 20 years? I want to be walking down there with him. I want to be strong enough to do that. So I got to start thinking about it. I got to start planning about it. 20% of women will fracture their hip if they live to an old age. That's huge, right? This is with or without breast cancer, right? So this is not even related to the additional risks we have with having breast cancer. And from that 3/4 of the statistic, 3/4 of the people that break their hips are women. That's about 225,000 a year. If we just say, hey, about 20% of those will die in the first year, which we saw in the Danish data, that's 45,000 women a year are dying within a year of a hip fracture in the US. That's actually more than die of breast cancer, right? So this is why we need to really start thinking about our toxicities of treatment and just our survivorship roles. It is hugely important. Not smoking, clearly, right? One of the hardest habits to kick. You know, for those of you that don't smoke, please don't start. For those of you that do, understand it is hard, right? I've had patients go into rehab and they kick their heroin, they kick their cocaine, they kick, but they still smoke. It is a tough addiction to quit. I get it. I also get that I treat a lot of lung cancer too. And I've had so many lung cancer patients that were a pack a day, 2-pack-a-day smokers. The day they get diagnosed with their lung cancer, they quit, right? So something switches mentally. And it's kind of like the straw that, breaks the camel's back. Or I've also seen patients that decide to quit because a grandson or granddaughter asks them, or something, they told themselves when they were 20, if they were still smoking at 50, they would quit. And that's what I see. But there's many ways to kick this habit. But please know that there are helplines. Advocate has groups, Gilda's clubs, things like that will have smoking cessation. You can learn from each time, even if you quit for 2 weeks. If that's the longest you've ever done, that's 2 weeks that you've done without quitting. So the next time you quit might be 4 weeks, might be 4 months, might be 4 years, right? If we keep learning from that, that's important. You don't have to quit alone. Support groups, we talked about that. Advocate has some. I was going to update my slide, I didn't, but there are quarterly advocate sessions that we're going on Zoom, so you can find them on the advocate site. There's medications, gum, all of that good stuff. And just knowing, I think, like having seen so many patients that do make that decision, it's just somehow it's the day before you're diagnosed with lung cancer and the day after you're diagnosed with lung cancer is not different in your body, but something switches in your mind. So figuring out how to do that switch in your mind, it's important. So stop smoking. Healthy body weight. So I just alluded to this, but again, surrogate, body shaming. So like, don't aim for a number, but aim for something that is healthier than where you are, I think is a good place to start. Body mass index is actually a somewhat complicated formula. You can plug it in, but it's basically your weight in kilograms divided by your height in meters squared. There's American versions. You can put in 5'2", 145 pounds, it will spit out a number. And you're aiming for about 20 to 25. The more muscle you have, the higher that number can go, because muscle is much denser than fat. So it's just a surrogate. It's not, don't get too hung up on the number, but aim for something healthier. I am super passionate about a lot of things. So these are speaking to the question, why aren't we talking about these things? There was a book somebody mentioned, Crispy or something. I haven't read that one, but I was like, oh, I should check that one out, right? So I read these books because I'm interested in them. And if I find one that I think, I think there's a lot of sound medical advice in here, or, I share it with my patients. So definitely I'm interested in lower carb living. You'll see why. I'm going to put up some graphs about sugar consumption and, why I'm worried about that. I'm interested in intermittent fasting. That just means we have sort of a timed eating window. It means we're just not eating all day, right? So these days we start eating first thing in the morning, then we have a snack at 10, and then we have lunch, and then we have a snack at 2, and then we have dinner, and then we have a snack before night, and we're eating all day. That really is a very new phenomena, and it's probably not a healthy one. And there's, it's not to say it's not to say that this is the be all end all, but this is a place to start, to maybe think about like, why is it like grandma never did that? Like grandma and grandpa would be out, milking the cows, doing stuff. They wouldn't have breakfast until like 10 o'clock in the morning, until after all the animals were fed. And then they probably wouldn't have lunch because they just ate at 10, and then they'd have dinner, and then they'd go to bed early, right? So they had 2 meals a day. If we go even before that into our hunter-gatherer society, which evolutionarily or by design, however you want to think about it, wasn't that long ago, right? We didn't eat 5 times a day. It's probably not the best approach. Work with a nutritionist. Some people do very regimented meals 5 times a day, but being conscious about these choices, I think it's important. Oops, sorry. CBT, Dr. Roselle mentioned that. Cognitive behavioral therapy, super powerful. It's where there's events that are triggered that everyone can see, but your thoughts and your reactions and your feelings, all of that can be controlled. So I really like Dr. Katrina Ubel. She's actually from Milwaukee. She's just up the road. She just wrote a book. So she's always done this podcast, and she's a coach for actually weight loss for the busy physician. Right? That's how I found her. She's amazing, I think. And I find her techniques are just really approachable. So, I recommend, especially now that she has a book that's not just directed to women doctors, I'm like, read about this, like understand, we eat when we're bored, we eat when we're tired, we eat when we're sad, we eat when we're celebrating, right? Marriages, baby showers, all of that. But maybe we can address all of those feelings without eating, right? And serve our body better. Medications, I'll talk about this in some more detail. Super excited about this. I'm starting to see a lot of patients now, like Dr. Roselle says, I have a lot of patients that I just see once a year now because they're 10 years out from the breast cancer diagnosis. And what I've seen in the last few months that I've never seen before is these patients are coming back and they are losing weight without trying. And some of them are worried about it. Like I had quite a funny experience with this one patient who was just so worried because she didn't have an appetite anymore. And she'd already had a workup and her cancer was not back and it was an early breast cancer. But I knew she had been a diabetic for a long time. And so I'm like, have any of your meds changed? Is anything going on? Right. But patients forget. It's been a year since I've seen her. And I actually asked her, I'm like, have you started on Ozempic or Mounjaro? She's like, oh yeah, I started on Ozempic a year ago. Well, so she'd been started on this medicine for her diabetes, but as well as controlling her diabetes, it leads to decreased appetite. And so without trying, she had lost 35 pounds over the year. Her diabetes was better controlled. She was super worried about her cancer coming back. But once we had assured her about that, it was really a great place to hear, but she's like, Dr. A, you just don't understand. I'm just not hungry. And I was like, but that's great. Like that is exactly, we don't want that food chatter to be constantly dictating your choices. I'm like, please carry on with the Ozempic. This is great. So she was actually the lowest. The other one was 50 pounds in the year. And I think there was one that had lost 65 pounds over the year on these meds. So after that 1 week, it was like back-to-back patients. I saw like in one Thursday morning clinic, 3 of them. It was like, okay, I need to go read up on these medications, right? Like I knew about them, but I didn't know much because this is not my world. So I refer people back to their PCPs, but they are super powerful, I think. Why do I think low carb and that intermittent fasting is important? Well, we just know sugar consumption is going way up. Again, this is not how our grandparents ate. Sugar was expensive. Fruit was expensive, right? I remember when I was growing up, I'm not that old. We never got oranges except at Christmas, right? Christmas came out, you got the little clementines, you were like, woohoo. But the rest of the winter in Canada, you didn't get oranges. But now every time you go to the drugstore, food store, you can have whatever fruit from whatever part of the world you can. You can have whatever sweet you want, and so we have started consuming way more sugar. So this graph, I think, is really, we'll talk about it, but this is the 1820s, and this is pounds per year per person of sugar. So we barely ate any sugar 200 years ago. And even before that, hunter-gatherer times, things like that. I mean, it was almost nothing, right? So again, by design or by evolution, our bodies probably aren't that great. Well, I'm not going to say that. By design or by evolution, our bodies may not be that great at dealing with these excessive amounts of sugar that we eat now. And you can see just how much has gone up. So this goes to about the 2000s, and we're now topping 100 pounds of sugar per year, right? That's huge when you think about the changes that have happened. It's everywhere. You have to start looking at labels. You have to start thinking about it. You have to start eating less processed food. So I'm really excited about the cooking demonstration because I'm assuming that that's going to be part of it. But these are changes that we can make. And I'm not saying, no, we'll get on to my next slide. I'm jumping ahead of myself. What about, diabetes? Diabetes runs in my family. My dad had diabetes. My mom had diabetes. Diabetes is correlated with a lot of different cancer diagnoses, recurrence risks, cognitive decline, right? So these things scare me because it runs in my family history. And so once I started looking into the data around things, look at this map, or pardon me, this graph about the percentage of the US population diagnosed with diabetes. It is both in percentage, is the yellow, and number, right? So again, 1958 wasn't so high, and now look at the skyrocketing. Now, I'm not saying this is related to sugar consumption, but there's certainly some correlative effect. I don't know if it's causative, right? Those are different things. But, this is concerning. And diabetes has so many health implications. It affects your eyes. We call it end organ damage, but it affects your ability to see. It affects your risk of heart attacks. It affects your risk of stroke. It affects peripheral neuropathy, right? These are big deal issues. So if we can prevent diabetes, we should, in my opinion. And even more scary than that is the amount of pre-diabetes that's going on. A lot of people tell me like, oh, Dr. A, it's okay. I'm just a pre-diabetic. I'm not a diabetic. I would posit, or I would suggest that at the point where you already have an elevated hemoglobin A1C, your body is seeing a lot of damage from that. We don't call it diabetes yet. It's not an official diagnosis, but I would say I'm worried. Like a lot of people said, oh, my doctor said I'm okay because I'm just a pre-diabetic. And I'm like, oh no, if you're a pre-diabetic, like now, we need to act now, right? Well, here's the scary thing. CDC estimates that 80% of people don't recognize that they're pre-diabetic. So please check your hemoglobin A1C. It doesn't need to be yearly if it's not a problem, but certainly once you're over 40, if your BMI is over 25, if there's a history of diabetes in the family, please keep an eye on this. Because at the point where you're pre-diabetic, I would say you're probably 10 years into your diabetes journey, even though we don't call it diabetes yet. Correlation versus causative, right? So this reminds me to say like, and I think Dr. Roselle did a really good point of pointing this out, right? I'm not saying sugar causes diabetes. I'm not saying sugar causes cancer, but we're seeing these increases, and it's certainly something that we can maybe adjust. But remember, correlation, not causation, right? So this is a graph of shark attacks and ice cream sales. They look pretty correlated, right? Probably not causative. Probably the fact that I bought a Ben & Jerry's ice cream cone didn't cause my shark attack, right? It's just probably like shark attacks happen in July, and that's when I eat Ben & Jerry's. But so, take all of this with yeah, maybe I can do better, but like, don't get like, view it as something that you can maybe change and modify and work on, as opposed to something that is the absolute be all and end all. That being said, right, correlation is not causation. I did want to put this graph up again. So now we're seeing like the sugar rate going up. This is high fructose corn syrup. That's a really new invention actually, but this is sort of peaking and it's coming back down because I think we started putting it in all foods and now people are like, oh my gosh, like, no, this is not a healthy form of sugar. And in fact, I got some Halloween cookies just now and it's like, no, added high fructose corn syrup, right? So we're seeing that coming down. We're seeing TV ads going up. But look at this, US obesity, it's going up. We don't know exactly what it is, but maybe we're watching too much TV. Maybe we're not walking too much. Maybe we're eating too much sugar. These are all things we can adjust. It doesn't mean that this curve is going to go down, but maybe it will. Maybe we'll hit the one like the smoking curve that I showed, and that's why I spent time on that smoking curve and the stomach cancer curve. If we can see that, yeah, these actually are the causes of these issues, correcting them will help. It's going to take decades though. It's going to take decades for that curve to come down. So anyways, this is like, I'm all about being practical. I'm really blunt. And I always tell my patients, if I'm being too blunt, I can tone it back. I know I'm passionate about this. But yeah, how's the diet going? Usually not that well, right? It's tough, right? Dieting is tough. And so like, and I'm never going to tell you to run a marathon because you know what? I'm not going to run a marathon, right? So I only suggest things which are accessible to me. I work 10 to 12 hours a day. I commute. I have kids. Life is busy. So it's got to be something that I can fit into my day, which is why track your steps, right? Because you can tell at the end of the day, ooh, 3,000 steps, right? That's easy. So now go walk the dog, right? Walk, yeah. But we talk about these things. I don't leave my patients out in the wilderness on this. This stuff is important to me. This I just thought was, I mentioned looking at labels, right? Labels are important because you know what? It's hidden everywhere, right? Like sugar is just everywhere. So on the left are quote unquote healthy choices, and they actually look healthy to me. Like that Dunkin' Donuts banana chocolate chip donut does not look that bad to me, but it actually has more sugar than something that, yeah, okay, that probably I can decide isn't that healthy for me, but you know, they're actually the same or worse in calories and sugar content. Yogurt looks pretty healthy, right? That's a healthy choice. Yeah, look at the label. Maybe it's not the healthiest choice. Maybe it's the same as having ice cream. Doesn't mean you can't eat it, but moderation, know what you're putting into your body. Pancakes, this one's on the next slide. I mean, these two I thought were, I had no idea. Like, so a cup of Quaker oats and honey natural granola, like that seems super healthy to me. Well, it's about the same as 5 Oreos, right? So like we have to question these processed foods. Just because it says healthy on the label doesn't mean it is. And then the same thing, I think this granola bar looks super healthy to me, but it turns out it's actually a worse choice than an O. Henry bar. So go eat the O. Henry bar and make the healthier choices, right? Like you're allowed to eat the O. Henry bar now and then. And then, but you know, don't fool yourself to thinking that this granola bar is a healthy choice because it's not. Probably. Oh yeah, sugary drinks. They are the bane of my existence. This is actually one slide that I'm going to say I did pull it from the internet, and I think it's accurate, but I didn't fact check this one as much as I want. But sugary drinks, if there's going to be one change that you do, stop drinking sugar, real and fake. So fizzy drinks, unless they're like carbonated water, please get rid of them. Like no Coke, no Diet Coke. Juices, and I'm even not a fan of juicing, right? Like people are like, oh, I'm doing kale and I'm doing this and I'm doing cucumbers. I'm like, that is great. But I'm like, how much stuff goes into your blender, right? And so the patient's like, oh, it's amazing. I have like a pound of kale and a pound of, and I'm like, you know, there's actually a lot of good work that happens by your mouth and your stomach digesting that food. If you throw that all in the blender does that work for you. And suddenly you're eating way more food at a sitting that you would have otherwise. Because no one's going to, I mean, I love kale, but I'm not going to sit down and eat a pound of kale. Like, I can't, I cannot physically eat that much kale. So just be careful, even with like things that seem healthy, even things that seem unprocessed, right? You're putting it in your blender. You know, you need to be aware of what's going into there and that it's taking a large amount of food and making it easily digestible in like a short amount of time. And then your stomach gets full because it's a liquid that doesn't feel full. I just want to go back to these two medicines. Again, I had to look them up. I hadn't heard about them, but I'm just seeing so much success in my patients in the last few months. I try not to use brand names, but they are unpronounceable. So there's semi-glutide and tirzepatide. So I'm gonna, you know, I'm sorry, but I'm going to call them Ozempic and Mounjaro because I can pronounce those. But please talk to your PCP. I'm just seeing these patients. I'm seeing the stories and I'm seeing it working. Some of them have different indications. Ozempic and Wegovy, they're the same medicine. One of them is indicated for diabetes and one just for weight loss. Mounjaro is currently just indicated if you have the diabetes diagnosis, but Lilly just announced a trial. So this drug is by Lilly. I think this week that they're now doing a trial that you can get onto that is just for weight loss. So if you have obesity without the comorbidity of diabetes, and of course, if you're on a trial, right, we need the research, amazing stuff. All of your drug costs are covered. You might be into the placebo arm, but usually they let you cross over later. But at any rate, these drugs are exciting. Talk to your PCPs. Super exciting. So in summary, hopefully, I don't know how long I've nattered on. In summary, you know, I wanted to talk a little bit about radiation. Obviously, I'm passionate about that. I'm a radiation oncologist, but I also really am passionate about the survivorship, the exercise, the weight loss piece. And I hope I could present to you why that is. And really just the goals that I'm excited about and always happy to talk about. But I really thank everybody for their attention today. And I'll leave it open to questions. Thank you.
Right to the next.
Mhm.
And then you can,
Did I go like way over? Yeah. Oh my God.
Thank you so much, Dr. Aippersbach. That was wonderful. All right, so we're going to move right on to our next speaker. I'm excited to introduce Dr. Denise Furlong. She completed medical school, her internship and residency at the University of Illinois. Her fellowship was Illinois Urogynecology. And Dr. Furlong strives to fill a void in the healthcare world with the purpose of providing a safe, compassionate, patient-focused environment to empower women to live happier, healthier lives. I've heard her speak at many different programs. She's amazing. She's double board certified in female pelvic medicine and reconstructive surgery and obstetrics and gynecology. And she also speaks Spanish and English as well. And she founded the Chicago Center for Women's Health and here at Oak Lawn and in Bedford Park. So let's welcome Dr. Furlong. Thank you.
Hi, everybody. Thank you, everybody, for being here and all of your efforts. And let me get my earring back on. In my bags, I just wanted to tell you the pen that's in here is a sanitation pen. It's really kind of cute. I'm going to demonstrate it. I know, right? There we go. So if you take off the top, it sprays. So you can clean your hands if you want to keep a pen in your purse, and it comes out and you can refill it. Okay. So my bags are up at the top. How do I switch the screen? Can you let me know? Is it this computer? This one?
Yeah, there's one on the right.
This one. Okay. So my talk is about sex. Can everybody hear me okay? Okay, right? And what did I want to say? Oh, that's it. Is this the pointer? Got it. Okay. Synonyms for sex. So I'm not talking about sex like a boy and a girl. We're talking about sexual intercourse, coitus, copulation, fornication, lovemaking. And I want to let this open up to the audience because I want to see what people use for other terms for sex. Does anyone have any other terms that they coin for intercourse? Any hands up? Oh, no, we have to say things publicly. Any other words that we coin for intercourse, for sex, for fornication? Does anybody have any little like adult time? Okay, adult time's a good one. And getting it on, right? There's another one. Anything else? Smashing. Very good. Anything else? Anyone else have any terms that they've grown up with or heard or used in the bedroom? Nookie. Whoopee. That's right. That's right. I actually had to look some of these up. Mating and hooking up, right? So, sex is something that we all talk about, and we coin it in many different ways, right? Kind of cute, sometimes kind of vulgar, sometimes kind of sexist, right? So sex is a very loaded topic, right? It's something that, is really taboo in our culture. We don't tend to really talk about that topic. And there's a lot of reasons why. And being a predominantly female crowd and myself as a female pelvic reconstructive surgeon, I mainly treat women. I talk about sex all the time. This is a very comfortable topic for me. I'm a vagina expert, right? So, kind of like the breast experts, we're the vagina experts. So sex is always something that we're talking about because we're intimately part of that woman's body and their life, right? I'm changing women's lives when I reconstruct their vagina. So I'm talking about sex. I'm talking about intercourse. I'm talking about what they need. How are their relationships with their partner? How has sex progressed? And so for me, it's very easy to have these conversations with patients, but patients aren't always easily patients can't easily ask their providers if they're not coming to someone who does this on a daily basis, right? So it's nice to kind of look at sex and think about it in a way that opens it up. I think we're at a level in our culture and in our world, in our society, where things are becoming a lot more open gender differences and sexuality, and all these boundaries are being pushed. And so with that, hopefully the taboos and the stereotypes and the discrimination for women and the ideas of sex and sexual intercourse and pleasure, those boundaries can definitely start coming down, and women can have more of a voice and more of a, the ability to participate in sexual intercourse and enjoy it, and without feeling shamed into that. So I thought that was kind of cute. Some synonyms for sex, as there's like, 50 on Google. It's kind of cute. As I was looking up some basic stuff, I went to the Webster's Oxford Dictionary definition for sex, and I'd like to read this. It's sexual. This is, if you Google, and everybody Googles, right? Some Yahoo, but I Google. Sexual contact between individuals involving penetration, especially the insertion of a man's erect penis into a woman's vagina, typically culminating an orgasm in the ejaculation of semen. We all know that, at this point in our lives, that there's a lot of different ways to have sexual intercourse, and it doesn't always just include that. And so as much as we are a mainstream society, in our thinking, I want to stop and say that even though my lecture is a little bit more mainstream and heterosexual, there are lots of different types of intercourse and types of relationships. So it's missing masturbation, oral sex, anal sex, and sex between other people that are not heterosexuals. So we're talking about the lesbian, gay, bisexual, transvestite, and queer population, right? So I am not going to touch on a lot of that, mainly because it ends up being a lecture that would be a few hours. So I'm going to leave it more towards a heterosexual type of relationships, and basically just some basic stuff about intercourse and sex. Let's first go over some anatomy. I'm always surprised that, when I talk to my patients and I start talking about the clitoris or, the labia or this, and my patient's like, I don't talk about that, Dr. Furlong. I said, well, what do you mean? I don't touch down there. I'm so embarrassed. And it's very interesting, and it's not just my geriatric elderly population. I have younger patients too, who are very bashful on looking or thinking about their anatomy. I have young girls who have no idea how to masturbate or where their clitoris is. And so we take mirrors and we look at anatomy, and I do lessons, and it's very basic. So I wanted to go over that just to make sure everybody really knows their anatomy. So I'm going to step away from the screen for a second so I can point. And so this is the clitoris. So if a woman puts her finger in her vagina, okay, and you're putting it this way, right above, a separate opening is where you urinate. I wanted to get a video clip of Orange is the New Black. Was that the one that the girls were in prison and they had? So that scene is just classic. I love it. Oh my God. I remember I was watching it one night and I was like, I want that clip for my office. She's in the bathroom. And so it's really cute. So yeah, there's separate openings. And so a lot of my patients will ask me when I'm doing certain surgeries, if I'm doing a procedure where I close a vagina, which is a different topic, they ask me how they're going to pee. And so they are separate openings. It's kind of like our nose and our mouth, right? If you poke a hole through the roof of your mouth, you're in your nose, right? They're separated, but they're definitely in the same area. So, and then here are lips. So the larger ones are majora, like majority, so larger. Minor, the little ones here. As women get older, these two will become flush, and you might not see the differentiation between the two, and that happens with menopause and with the lack of estrogen. So some of the anatomy starts to change a little bit. Let's see what, oops. And then anus, this is a perineal body. The distance between the clitoris and the urethra is about 2.5 centimeters. They look at that distance to determine, not determine, but kind of to look at studies between women who can orgasm with intercourse versus needing to have manual stimulation. It's very interesting studies. And they think that the shorter the distance, the easier it is to orgasm during penetration. So those are some things they look at. The clitoris is the pleasure center of a woman. It's a complex network of erectile tissue, meaning little muscles that when they get stimulated, they all contract. Similar to the penis, where it gets hard, but it's erectile tissue, it's muscular, not just vascular. and about 8,000 nerve endings. So it's kind of funny. I was at this event and someone said, "Oh, there's the neurosurgeon. She's a brain surgeon." I looked over. I was like, "Oh, me?" They're like, "Yeah, aren't you a brain surgeon?" I started laughing. I said, "Pretty close. I'm a vaginal surgeon." Oh my God. So was that a Freudian slip or what? I was like, "That's right." But anyway, and then everybody has heard about the G spot. The G spot is an actual spot. When the clitoris goes into they're called curae, they're like legs. And so it's kind of like a wishbone. The clitoris is here, and then you have like two arms of it where the nerve endings go, and they actually go in towards the vagina. So even though they're on the surface, they kind of go in. And where they go in, they kind of converge to where it's technically called the G spot, and that, or the Grafenberg spot. And so if a woman puts her finger, or someone else puts their finger in their vagina, kind of like calling to you, like, "Come over here," and you stimulate that area, you can have an orgasm. So that's the G spot. It is an actual spot. So if you ever want to discuss that at parties, I'm always very popular at parties, by the way. I just want you to know. After everybody's gotten a couple drinks, all the guys are like, "Hey, Denise, I have a question for you." I'm like, "Oh my God," right? And I'll tell you, it's really interesting because by midnight, I've got like a couple tables and I make my rounds, and the questions that I'm asked are good questions, right? And then I'm usually, someone will show me a video saying that they're trying to prove their point. It can get pretty bad, but I try to, and that's when I start to leave. But the G spot is really true. So I do tell that to all the husbands, and the wives are very appreciative. Okay, so now we're talking sex. Sex was always, I started my talk. It's a taboo subject. No one wants to talk about sex. It takes a couple drinks for everybody to really loosen up and start to talk to me at parties, right? They're not going to meet me and start asking me. And pretty much with us too. Like, I'm looking at my kids growing up and I'm thinking, how am I going to talk to them about sex? I even, kind of wonder that, because it is a hard topic for everybody. Sex really started getting studied in the 70s. Kaplan and who was a female, and Masters and Johnsons, who were a couple, and they started looking at the sex cycle, right? How do people become sexually active in an interaction, right? Like, we're all sitting here, and when we go home, we are with our partner, and how are you going to have sex? What happens, right? So they look at this course, and it starts off with some excitement, and then you get plateau. This is the actual acts of intercourse, an orgasm, and a resolution. So when we look at orgasm right here, for women, this can peak and they can have multiple orgasms, and the resolution phase is very short, and they can go right back to excitement very fast. This is more of a male model, where they have one climax and a resolution, and it takes them a long time to come back here. So the male model is different than the female model. Also, the male model, they excite very much, they excite faster. Excitement in a woman is much different. And that's something that I'm going to talk about in the next slides. And that's where most of the talk is going to go through. I didn't put a slide about this, but I think it's interesting to know. And I wish now in hindsight, I wish I had. I try to limit my slides. There was a really interesting slide that showed that when boys are becoming sexually active, their learning curve to learn how to orgasm is 2.5 to 5 years. And 100% of all men will learn to orgasm, okay, in 2.5 years. The curve for women can take about 20 years, and only 90% of all women will orgasm, ever. Men have a lot of work to do. That's why they come to me at the parties, because we want to get it 100%, right? It's a lot of work for, not getting reciprocated, but that's the truth of it. Why? Taboos. We don't talk to women. Women aren't supposed to enjoy sex. I mean, they go on and on and on, right? You're not, if you have sex, you're promiscuous. If you have sex, I can go on and on about terms, but I'm not going to, because I don't think they're kind. And hopefully we're changing as a society. But this is the basic model that is still referred to 50 years later, and it's changing a little bit, but not drastically. And it's a good model. I like it. I think that it shows us all these different phases that are happening with our body in terms of our blood pressure, our heart rate, our breathing. Okay. When we look at that, I'll take questions at the end. Thanks. Okay. When we look at that slide, we talk about the initiation of sex, and this is an important slide for women. When we look at the initiation of sex, there's two ways a woman can start to have sex. Well, there's actually three, right? They can just have sex, and and that's it. They're without any thought processes whatsoever or physical changes. But we're not talking about that. We're not talking about trauma. We're not talking about rape. So those things are off the table. This is either just interactions between a couple or however the interaction is. When we look at desire is different from arousal. And as I was reading, it became very clear to me that one's a brain and one's a body. Brain, this is what the brain says. Ooh. Now for me, I am heterosexual, so I'm going to use myself as an example. Ooh, he's really hot. Ooh, I want to kiss him, right? Brain. I get excited. I think about it. I thought about it. It has a reaction in my body. I start to have physical changes that make me want to have intercourse and engage in that, right? Here's a second situation. This is the body. The body is you're washing dishes, you're vacuuming, right? I don't know about you guys, but I do a lot of housework. My honey comes up behind me. I'm like, get away from me. Can't you see like I'm washing? Oh, that's kind of nice. Okay, right? You weren't thinking about sex, but someone came up to you and they did something and they really got you interested. That is arousal, okay? So they're different, right? Very easy. One's a brain. You're thinking about it. You're stimulated. You read a book that has a sexy romance scene and you're like, oh my God, I can't wait till my honey comes home. And you're thinking about it all day, right? And the other one is that you're physically changed where you're at and it causes a reaction in your body. You can have problems with both of those systems and so for women, remember when I was talking about this slide here, women may not ever get off this line on the bottom. They may never get up this ramp. Men just go around and around and around after they doesn't take them much, right? For women, it's all stuff that has to happen to us. We're definitely hormonally driven. Men too, but in a different way. Okay, so when we have problems with either of those two systems, right? We look at desire, the brain. That's a hypoactive sexual disorder. I left a lot of the medical terms out because I really want you guys to just get the gist of what's happening, because it's not really, the labels are not important as much as what's happening to me and why, right? So when we look at desire and the change there, it's a brain thing. I'm not thinking about sex. I'm tired. I'm exhausted. I've been working. I've had radiation. I've just gone through chemo. I'm worried about making it to the next day, right? Your brain is somewhere else. Your desire for sex is just out the window, right? And it doesn't just happen with patients who have breast cancer. I mean, 46% of the female population can have this problem, right? Whether it's surgical, medical, and menopause. So we're looking at those three situations where you have very low hormones. So, I always, my menopause patients come up to me and they're like, oh, my sex drive is gone, Dr. Furlong, give me something for it. We'll talk about that in a minute. But it's equivalent of being castrated for a male, right? Our hormones are gone. It's very hard to have lived your whole life menstruating and having ovulation. And there are MRI studies that show during ovulation, if you're shown a picture of a romantic situation, your brain fires more than if you're not ovulating. And that's our biological response. Our chemicals, our hormones are doing that. They're driving us to have sex, to procreate, right? And then, of course, we continue to procreate for pleasure reasons. So chronic OCPs are oral contraceptives. So women, I have a patient who's been on birth control for 10 years and her libido is gone. She finally got off of them. She just got married and she's trying to get pregnant, but she has no libido. So we're working on that. It's going to take some time to kind of get her ovarian reserve to, start kicking out some hormones for her. Premature ovarian failure, very similar to if somebody had their ovaries removed. Premature ovarian failure is the loss, is going through menopause before 40. So those are problems with desire, hormones that affect your brain and affect your ability to want sex, right? Because you're preoccupied, you're doing other stuff, or you don't have the hormones that are helping you. Then you have the arousal, the body, right? So you have vaginal dryness. Well, vaginal dryness occurs when you're on, medications that inhibit all of your estrogen, right? And so you have dry vaginal skin. So you had trying to have penetration or digital stimulation, and it's dry. Dry means no elasticity. That means, when something wants to go in and stretch the vagina open, it's not going to happen, and that's painful. Right. So you're having painful sex. And if it's painful sex, you're not going to want to have sex, right? The body. And so your libido goes, right? It's painful. You want to stop it. You might have bleeding from painful sex, from dryness. You can use Uber Lube. I saw that there. There's lots of products. There's Sliquid. Astroglide is super easy to get. And then all the grocery stores. I'm not a fan of KY jelly. KY jelly, when you have intercourse and you have the genitals moving back and forth, there's air. And with KY jelly, it tends to get really sticky and tacky. So I like things that are more like the WD-40 of sex. And so Astroglide is like that. Uber Lube is like that. And don't use WD-40, okay? You go home, you'll be like, Dr. Furlong told me to squirt up some WD-40. No. There's just the viscosity. We're looking for stuff that doesn't dry up in the air. I don't know how KY jelly got so popular. I don't know, who did they pay in their marketing? Because I don't know if they've changed it, but when I've tried it, and I've tried a couple of formulations recently, I didn't like it. But anyway, there's a lot of good products on there. There's water-based, there's silicone-based. I like both. Some people like just water-based products because they're, more natural. Either way. Hypertonicity is a fancy word for tight pelvic floor muscles, I kind of think of it like if someone's going to punch me, I'm going to go like that, right? Like, no, don't hit me, right? And so your vagina kind of does that. It sees a penis or something coming at it, and it's like, right? So that happens when you have vaginal dryness, and it's painful, right? Sex is painful. So your muscles are going to remember that event not being fun. And so your body just stays that way. Because if I did this, I'm not going to walk around like this all day, right? I was like, okay, that's over. I can walk. But your vagina, it can't see that the event is gone. So it's going to stay contracted. And so those patients have other issues. They might have urgency, frequency, pelvic pain, can't have intercourse. It could start from vaginal dryness. It can start from trauma. It can start from a lot of things, right? Anorgasmia is just someone who doesn't orgasm. Well, we already know 10% of our women population don't have orgasms, right? I cannot tell you how many women I have talked to, young and old, who just don't know how to orgasm and never have. Hyposthesia is just, some decreased sensation. This is very common as you get into menopause anyway, and you decrease your estrogen. It takes longer to climax. So if we went back to the first slide, this plateau is really long. And then when you climax, instead of it being a wow, it's a, oh, that was really nice. But that's not what you tell your partner, You guys remember, oh my gosh, what was that movie? Oh, I'm forgetting the name. What was it? Yes, where she has the orgasm at the table. That's classic. That was classic. I was like, I gotta keep that. See, that's another slide I got to incorporate into these videos. I'm definitely gonna be better than my next lecture. Okay. Let's look at sex hormones and neurotransmitters. Here we're gonna throw out a bunch of fancy stuff. And we look at dopamine. Dopamine is on both, right? Dopamine here, we have dopamine here. We have estrogen here, we have estrogen there. Here we have serotonin, testosterone, no testosterone, norepinephrine, and prolactin. Does it matter? Not really. Because, these things are still being elucidated and there's a lot of overlap. The main point with this slide is that the predominance of different hormones in our body that we have naturally will affect us. And estrogen's on both of them. So as we go through menopause or we're on anti-estrogen hormones to decrease our risk of having a recurrence of breast cancer, we're going to go through menopause and all that's gone. And there goes our arousal. There goes our libido. There goes our desire. And then you're like, get off of me. I don't care how cute that is anymore. And you continue washing your dishes because that's more important than getting some nookie, right? So this is all really hard. And you can't go and take estrogen because, that's what you're trying to prevent. So it's really hard to get that back, right? dopamine. So all of our patients who are on Lexapro, Prozac, it decreases your dopamine, and that's a natural stimulant. So you always look at the risk factor. I don't know if they have them on the television commercials that when you're on these antidepressants, you may have a decrease in libido. That's, that goes both ways though. If you're really depressed, you're not going to want to have sex anyway. So a lot of times patients who are adequately treated do engage in more sex because they feel better, but then they are up against, not having the hormones, right? Can we supplement? Out of everything that's here, testosterone is the one that you can supplement, but it's not FDA approved, but it works. Gives you a little hair, but a little bit of acne, a little bit of male pattern lipid profile, which is cholesterol stuff. But if it's important and the side effects and the risks, then you can go ahead and talk to your doctor about doing an off-label androgen gel that you apply to the skin on a daily basis. So treatments, that's where I was just talking about. There's estrogen, which we don't do. The Prastone, I like Prastone. It's a little bit expensive. It's Intrarosa. It's a DHEAS, which is a chemical that comes from a little gland above the kidneys, and that goes inside the vagina. It is not a hormone, so that's really nice that it helps with vaginal lubrication and elasticity. There's nothing like estrogen to help that get better. So you can talk to your surgeon and, your team if you can do like Imvixi, which is micrograms of estrogen. I like Imvixi because it's a tablet, so it's easy to put in the vagina. I don't like Vagifem because it's a dry tablet. The Imvixi has a little bit of triglycerides, a little bit of fatty in there, and it helps give you a little slippery, slidey. The ospemifene is contraindicated because it's an estrogen type use fancy words, agonist, antagonist. That means it likes it, it doesn't like it, it takes it, it doesn't take it, it stimulates it, it doesn't, can't use it. The non-hormonal, well, get ready for stuff that's just cost prohibitive. I have an underserved patient population, so I actually have to go back and like Google these every time I want to look at them because I never prescribe them and I never will. Nobody can afford that. $960 a month for your flibanserin and for the bremelanotide, it's an injection. The Valesi is better, even though it's an injection, because you can take up to 8 of them in a month. And when you inject the medication, it works within 45 minutes to help with your desire. And it works for 24 hours. So that's nice. I did not find the price on that, which means it might be super, super expensive, right? You go to the fancy store and you're like, oh, there's no price on that. Don't touch that. So, kids, don't touch that. But those are the non-hormonal, the bremelanotide works better, because it definitely increases, the desire. The Addy, it increases it. Women who had 5 sexual episodes a month had 5.5 for $960 a month. You get a half an episode of sex. I was like, really? I had to read that 5 times, but that's what it said. So we'll be prescribing that, right? Menopause. This is where, you don't have any more estrogen, regardless of your age. It's very uncomfortable. And, if you go through menopause gradually, it's a little bit easier because, you have time to adjust and things change slowly. But when you go through menopause from one day to the other and, it just kind of drops, it's very hard on the body. You get hot flashes, vaginal dryness, your libido is gone. With hot flashes, actually, I got an article this morning that there was a plant-based diet, and they stopped the patients. It was 44 patients. They stopped eating animal products, did a cup of soy, which I'm not a fan of, but soy something, and then the rest was plants, and their hot flashes were decreased. You can do layered clothing, right? You start off with, camisole underneath, and then you have, you just keep taking off throughout the day and then putting back on. You can do cooling blankets, which I didn't write down, and of course, hormone replacement therapy, and then non-hormone replacement therapy for hot flashes. There's a lot, which I'm going to talk about, which I like, and I use often. Then vaginal dryness, we talked about all the lubrications, right? Replens, it's nice, it's over the counter. You buy a box at Walmart. It now comes with 8 applicators. It used to come with 10 for $15. So it lasted 30 days. Now it lasts, 24. But every 3 days you put it in the vagina. It's non-hormonal, and the studies, the subjective results from patients and women say that they like it as much as having an estrogen. But remember, it's a topical. It's like putting a lotion on. So it's not really changing the way your cells work. You're not getting your elasticity back, but it helps. The progesterone, which is the intrarosa, and then estrogens, right? The low libido. When we talk about low libido, we saw those expensive drugs, right? That, sort of kind of work. There's, we just need more studies, and, that's a whole different conversation for me to have with anybody in regard to why don't we have studies on women. That goes back to our first slide in terms of women are not supposed to enjoy sex, and who leads trials, right, and research, male dominated fields, and who are the lawmakers, male dominated, look at our Senate, right? How many women are sitting in there? Who are lawmakers, right? Who's lobbying for us, right? And so, we don't have that voice because we're doing other stuff. We're getting paid less. We're taking care of our home. We're working, right? So who has time to go lobby and make sure that the researchers are actually doing something for us to have a great sex life? But that's a whole different story. The thing that works the most right now that's out on the market is cognitive behavioral therapy. So you sit down, you talk to somebody about how you can be more sexually active. A lot of the research shows the more you think about it, the more you read about it, the more you watch TV about it, the more you think about it, the more you want it, right? So you got to start with the thoughts. You got to read a book that's really romantic. You've got to watch movies. You've got to have more sex. If you have more sex, you want more sex. And it's just a cycle like that. So that's what women have for now for treatment. For hot flashes, these are 2 new products that are out. This is kind of cute that I thought it was Kiss. That's so cute. Kisspeptin, neurokinin, B-dynorphins, these 2 products, which I can't pronounce and I won't embarrass myself. A neuron complex, and I didn't put all the fancy words. There's a place in our brain called the hypothalamus, and right next to it is a thermoregulatory center. These 2 products that are non-hormonal will target the thermoregulatory center and stop hot flashes. They work really well. They're a little bit expensive. They just came out in the last few years. One got FDA approved this year. So I'm sure they're, first tier, not, or third tier, not covered, but, there's stuff that's out there. Other things I like for hot flashes that I didn't put down on my slide, is clonopine. It comes in a patch. It's a blood pressure medicine. I use that frequently. And then of course, like Effexor, and some other SSRIs that are really good low dose that really help with hot flashes and mood changes. And like 90% of all my patients love Effexor. So I do that one a lot. But there are others that work really well. I wanted to kind of end the presentation with another slide for the sexual model. I showed you the sexual model in the beginning. It was very linear, and that's more the sexual model for the male, right? Males are very simple. They're like a light switch. They're either on or off. That's it. We are like the kitchen. We've got a refrigerator. So sometimes we're cold and sometimes we're frozen. We're a little frigid, right? And then we get really, really hot, right?
I see
and
Ryan.
Then really wet, right? So we're like a whole kitchen. Then just turn on the light, right? So if you look at this, this says it all, right? We start with emotional intimacy, and this circle doesn't. Where does this circle start and end? Nowhere, right? Because who knows? We might be doing dishes and someone comes up and kisses us. We might have seen something really, cute, or read a really, interesting magazine that kind of gave us the, little kick, right? So we might have emotional and physical satisfaction here, starting emotional intimacy. We're seeking out and being receptive to sex, sexual stimuli, spontaneous sexual drive. Biological, and over here with psychological, sexual arousal and desire, and it just goes around and around, and then we get off and get back on, and go to sleep sometime. But this is by Basson, B-A-S-S-O-N, and it's a little bit newer of a model, but not that much newer. But you can see how complex it is, and it gets more complex. Those are a little bit simplified for the female sexual interaction. I wanted to end this with something on a very, very side note, something I didn't put in my lecture that's very dear and true to me, because as a very proactive woman, I'm very pro-woman. I wanted to talk about just kind of something that I've always felt for sexuality. And it says sexuality in women is complex and poorly studied, therefore poorly understood. Perhaps our social, cultural, and religious constructs have defined women's sexuality, and it creates barriers to treatment and have hindered openness to allow freedom of sexual expression. And so I hope as we move forward, and I'm really impressed that Christ asked me to talk about sex, because it's really, taking down the barriers and helping women understand that this is a natural thing and about ourselves and our body, and things are happening to us, and we need treatment, and we need to have, pleasure in sex, when we want to have pleasure in sex. And if we don't, that's fine, but it should be our choice, not someone else's, that the research is not out there, that the drugs are not out there, that we can't talk about it. And, there's lots of Facebook, the Why Me movement, the lesbian, gay population are really helping move sexuality more into being an open conversation. And these are really moving things for women. So I'm really happy about that, because I don't want my children to grow up thinking that, it's dirty for a woman to, have an orgasm and have sex or to touch herself. And so now it's time to get back in the game. Aren't they cute? All right. Thank you very much, everybody.